Aloha, everybody. I obviously am not Adrian for some reason. I am on a different uh, account or something technical that I don't have the capabilities to fix right now. So welcome to our Thursday, December 10th HiPAM webinar. Happy to have everybody here. Let me go ahead and share the screen. Thank you so much for joining us today. Good to see everybody. We have a super presenter today, Dr. Josh Quinn. I'm excited to introduce him in a little bit. So we'll wait one more minute and see if anybody's going to pop in, and then we will get started. Aloha, Andrew, Claire, Debashish, Ethan, Francis, who else? It's Vaughn, Jim, Josh, Yosh, Kealohi, Monique, Pratik, then H. Maeda, welcome. Okay, let's get started. I want to make sure we have enough time for Josh to share and to field a bunch of, I'm sure, great questions. So good afternoon, everybody. We're going to go through our update, COVID weekly update, and then I'll go over the science highlights and then hand it over to Josh to take over. So starting with our international overview, Japan is not showing any signs right now of decreasing, at least on a week-to-week trend, still continue to increase in terms of their 7-day case average. We'll continue to watch that very intently. In terms of the national overview, we were hoping that that downward trend we were seeing a couple weeks ago was going to continue. Unfortunately, it is kicking back up, and once again, that does concern us, even as we continue to implement our trans-Pacific travel testing. That surge, I don't even know, this continued surge in cases with the lag in hospitalizations and fatalities. We are now seeing more and more reports nationally that our hospitals nationwide, our fatalities will lag a little further than that. Going to our states that we highlight and continue to highlight, contribute a lot to our travel in terms of tourists and returning residents. So Arizona, once again, still showing no signs of that increasing trend. Same with California, even with additional lockdowns in California and Arizona, we're still seeing increase. Hopefully those lockdowns will start to bend the tide a little bit. In Nevada, around Thanksgiving time, a little before, we were seeing a downward trend, but once again, that was too good to be true, unfortunately, and we're seeing an increase once again. Same with Texas, a decrease a couple weeks ago, back to an increasing trend, unfortunately. So once again, hoping to see another downward tick and hold steady, especially as Andrew pointed out, Pfizer got an approval, and hopefully people are starting to feel more optimistic and just hang in there. Moving on to our local overview, cases per 100,000. Once again, a couple weeks ago, we were seeing an increase in Honolulu County, and overall in terms of state and Maui County. We have since leveled off a little bit, which is obviously good news. We want to keep any increasing trends to a minimum. Our positivity rate is still holding steady, which is great, even though we see some of these days with triple digits. Understanding that clusters may impact that. and also number of tests. So if you look at our positivity rate that adjusts for overall number of tests relative to the positive cases, we are still under 3%, and kind of holding steady right about that 2% for Oahu County, and statewide right at 2%. A big metric to keep in mind, even though we have increased our testing capacity and test turnaround time. Apologies for not including the slide last week, but if you look at this metric, which is 1 week lag to the date that we always present, we are holding relatively steady number-wise in terms of our testing turnaround between 20 and 24,000 within a 24-hour period, which is great, especially as we see an increased mobility in the upcoming months. And right with this, I will hand off to Levi to take over our forecast overview.
Hey guys, I'm back. Sorry about that. Can you hear me?
Yep, you're good.
Perfect. So right now, I do have the cases from a forecast perspective diverging. You see the pessimistic going up relatively sharply, and then our expected curve kind of remaining flat. And I truly believe this is the expected scenario. We've been holding flat now for several weeks. And the good news is that if we were to see a spike from Thanksgiving, we likely would have already started to see an uptick. So it's likely that there wasn't a really significant impact. We're not necessarily out of the woods just yet, but remaining cautiously optimistic there. So really expecting to hold steady in the next couple of weeks. And when you look at the gray lines that are overlaid on the case graph, this represents a bunch of the other forecasts that are modeled out as part of the CDC's effort, and they're all kind of projecting also flat. So again, cautiously optimistic about remaining flat from a case perspective. Deaths are going to keep steadily growing, but hopefully at a slightly lower rate. And again, from a hospital and ICU perspective, we're still holding steady at a relatively comfortable capacity as of right now. So, should all things remain unchanged, you know, we're doing all right, you know, especially when looking at the rest of the states right now. And just to give another perspective, again, this is the same data just represented in tabular form. So, you know, for cases, we're really expecting to stay around flat, maybe even slightly down when we're looking at the expected graph. The pessimistic, we're really hoping that's not going to be the case, you know, up potentially up to 40%, but again, likely going to be remaining in the expected. And the rest, you know, when we're looking at things like hospital and ICU, even when the pessimistic perspective, while the percentage is great, the raw numbers are relatively low as well. So again, while this is showing a high percentage increase, the raw numbers are pretty low. So overall, these numbers are relatively consistent for the next 2 weeks.
Thanks so much, Levi. So there was a lot of big news. I unfortunately didn't have time, so maybe Andrew, if you want to speak to this after I go over the two science highlights and speak a little more about the FDA or the community approval for the Pfizer vaccine, because that is huge news in terms of just the impact for the vaccines and also secondary and tertiary impacts. But two that both have huge ramifications for Hawaii. And the second one definitely for the rest of the world as well. I wanted to highlight. So the first one, only 44% of Hawaii residents plan on getting the vaccine, and that's from a UH survey from policy department. And then the second one, infected after 5 minutes from 20 feet away. There was an update from a study from South Korea that shows additional evidence for spread indoors. So first, from UH News. And the link is here, and you can get on the previous slide as well. From UH Manoa's Public Policy Center, they did a survey of a little over 600 respondents right after the November election. some major results that are really important when it comes to how we view the vaccine and the topics that we discuss here on our webinar for HiPAM. 44% of respondents plan on getting the COVID-19 vaccine. A large, over a third of them are unsure. But the good thing is that that's down from 7% from that from their previous survey in August. This is interesting. Once again, there's not much we can take from it besides the fact that this is cross-sectional and it helps us better understand that snapshot in time. 54% of men surveyed, 54% of the men surveyed were likely to get it versus 34% of females. And then this is something that I'm sure we all could have gathered, but in households that make over $150,000, over 50% of them were likely to get the vaccine versus only 28% of the PERS households. So once again, economic disparities in terms, and also probably translates to education as well. Looking at some other financial effects, 47% of respondents feel like the pandemic increased inequality within the state. And then mask compliance, which we know has a large impact on transmission and mitigating transmission. 81% of respondents responded all or most of the time complying with the mask wearing protocols when outdoors in public space. However, we see that drop to 40% compliance all or most of the time when visiting families. So once again, from education perspective, and also when we think about modeling and how to communicate this, it's really in the settings where we know transmission is most likely indoors with people where you feel like you can let down your guard, where mask wearing is most important, and continue to message that. And the second one, this really was just new. I think I saw this last night. So a South Korean epidemiologist found that the 6 feet distancing rule may not be enough. And due to South Korea's very detailed contact tracing, they're really able to nail down when there are cases, the distance that the infected and the infectee were what that distance was, and it was over our 6 feet or 2 meter rule. And this once again adds to growing evidence of airborne transmission and how that really impacts the number of cases that we have. So some major takeaways: may need to update our definition of what a close contact is. Currently, it's 15 minutes within 6 feet apart. That may need to be updated as we get more and more detailed and updated contact tracing information. And it may also impact how contact tracers identify close contacts and conduct their investigation. Specifically for Hawaii impacts, once again, the messaging from our group and from others within the community and our partners within the Department of Health is that starting with Halloween and through Thanksgiving and continuing through Christmas and the holiday season and New Year's, which are very historically very consistent with large extended family gatherings in Hawaii, for really messaging that and educating to really keep that small, if possible, to not have them this year, and if you want to have them, keep them small and within their guidance of our county guidelines, and even if you to have them wear masks the entire time, because once again we have more and more evidence that you can still spread it within 6 feet, even within that 15-minute contact duration. So just wanted to share these two important highlights with the group. Andrew, if you wanted to speak very briefly about, we have a few minutes before we hand it over to Josh about the FDA and Pfizer approval.
Hello everyone, this is Andrew again. So since we spoke last time, the FDA has convened and their panel of experts have voted majority to move ahead with the Pfizer vaccine today. This was just not too long ago today. While this is not FDA approval, FDA usually does not significantly deter from the panel recommendations. So we should see an approval of use for Pfizer's vaccine in the next week or so. So that's really exciting. Other things that are associated with it is only for sick adults adolescents and adults 16 years and older. Younger is still under investigation. The biggest things that they released from their data that they had was that it was efficacious across all of their subgroups when they looked at it. There was well tolerated. While it was tolerated, there were significant amount of mild to moderate adverse reactions. Injection site reactions were the highest one with 84% around. Fatigue was about 63%. Headaches in about 55%. Muscle pain in about 36%, 38%. Chills in about 32%. Joint pain in about 24%. And fever in about 15%. So there is some, adverse events associated with it. We don't know what the more rare side effects were just because of the number of patients in the study. Additionally, too, they did address the issue of are people who have the vaccine, are they able to transmit it? Unfortunately, they actually noted in their press release that they don't know enough information to be able to make that statement. They did say that if most people were vaccinated, there is some chance of it. But this is the first time I've seen it in an FDA release. They actually, in a side comment, more or less said that even if you get the vaccine, you should still wear your mask because they mentioned even those who are asymptomatic may still be transmitting, and it shouldn't be just because you get the vaccine should not mean means that you should not let your guard down though, which is very interesting for them to actually say in their statement. So exciting news. Moderna is probably next to follow, but exciting nonetheless. Thank you, Thomas.
Awesome. Thanks so much for that, Andrew. I know we all read the news, but it's very helpful to have a pharmacist speak a little more in depth to the vaccine, continued vaccine updates. So I'm going to stop sharing. Josh, whenever you're ready, if you can upload your slides, and then I'll give you a brief introduction while you do that. So for everybody on the call, I wanted to welcome Dr. Josh Quint, who is an epidemiologist within Disease Outbreak Control Division. He recently has started to work with HiPAM, and we're very happy to have him here, and looking forward to our continued working relationship and to just get at reducing transmission and educating the public with regards to COVID and other public health issues stemming from that. So Josh, go ahead and take it away.
Great. How's my microphone sound? Good. All right. Hi, everyone. Great to be here. Thank you for this opportunity to present. Just give you a real quick background, my bio. So I earned my master's of public health and got a doctorate in epidemiology from UCLA, focusing on infectious diseases and studying an HIV cohort. And then I came to Hawaii. I was really interested in just launching a career in public service, doing applied infectious epidemiology, and could not have predicted being here in the middle of a pandemic, but it's been a definite learning experience. I've been here 3 years in Hawaii, and I'm an epidemiologist with the Disease Outbreak Control Division, which is a division within the Department of Health. Let's see, slides are advancing. Okay, so I'll just start by saying that the pandemic has been from the earliest reports since, a new deadly virus coming out of Wuhan. We've been working almost nonstop, I would say, at the health department, my colleagues and I, trying to learn as quickly as possible to try to be able to put Hawaii in a good position to try to prevent morbidity and mortality that we have seen in many other places. And in DocD in particular, we see ourselves as playing a lot of different roles in the response. And I'm going to focus on just what I view as one of my priorities, which is to be just a steward of the data, the case information, and the testing data, so that we can just get that out as quickly as possible. We want people to have access to the most accurate data possible as quickly as possible, so that they can protect themselves. We also want to respect the privacy of our residents and our visitors that come here, because we know that our ability to continue to work with the community depends on trust. And so it's a tough balance to strike, and we're doing our best, but learning as we go. And I would say our overarching goal as a division and Department of Health is to share relevant data needed to inform policy decisions and timely interventions. So I know there's been a lot of criticism. A lot of people would like and expect DOH and DocD to be doing more. I would say that we're always looking for ways to improve, and we definitely appreciate groups like HiPAM coming in and filling in some of the gaps of parts of the response that DOH is not resourced to be able to address. So here's the overview. I'm going to talk a little bit real briefly about dashboards. I'll give some window into our data collection processes, and then I'll do just a kind of walkthrough tutorial of the data that we have, and just kind of sharing how you can get the most out of the information that we're producing. And then I'll open up, looking forward to some question and answer at the end, definitely. So I'll start off with this because to me, this is the epitome of the COVID dashboard. I mean, early on, we just saw Johns Hopkins University kind of enter the scene. There was just this scarcity of information. You know, something's going on in China. What is it? Has it spread? And I'm sure many of you were checking every day or multiple times a day, like I was, just trying to monitor, okay, what is this going to turn into? And I know I'm always going to associate this red dot. I'll probably be getting flashbacks in my dreams for a while, but I would say this pandemic has really pressed our resources and the limitations of data science of the health department, where, especially in terms of speed, it's very, I know it's a cliche to say things are unprecedented, but just the magnitude and level of the speed that's demanded of us, I would say is really new, and we've been trying to grapple with that the best that we can. So we tried to grow along the way to meet the need, and our current approach is there are two dashboards at the moment. So the one on the left is run by HiEMA, and we work really closely with them. There's a lot of data sharing that happens between agencies to make sure that everything's accurate and coming along well. So and I would describe their approach as the classic dashboard. I think it really makes sense from an emergency preparedness standpoint to get that situational awareness, to kind of have a quick overview. They got the links up there that you can jump into county specific information, but just, you know, your high level metrics, what's the current situation. And then on the right, that's the Disease Outbreak Control Division website. And, you know, that works along with HawaiiCovid19.com, and that would be the DOH level website. And in terms of our division, we really focus on this page because that's where we can tell more of a story. We're thinking of it less as a dashboard and more as a data story to give people a deeper dive into the epidemiology, to be able to track trends and patterns that are happening locally. So they're both updated daily. We hope that they're useful, and if you go several weeks without visiting and you come back, you'll hopefully find that things have changed. It's constantly in progress. I'll say that we are looking for ways to self-evaluate, and a resource that I found super helpful has been the Resolve to Save Lives agency. So we are using that as a framework and roadmap to guide which metrics, because there's unlimited things that you could measure. You really have to prioritize which things you're going to focus on measuring, which things you're going to continue to measure. Does it make sense to even still measure those things at different phases of the pandemic? And then which areas can we grow in? So I've really looked at this agency as setting a lot of good standards with knowing that they're led by the former CDC director, Tom Frieden. We feel that they have a good sense of both what metrics are needed and then what is reasonable for health departments to collect. That being said, this chart shows that the data that is most needed is really not available very widely. So the axis here, the x-axis, is the average score. So it's really on a 0, 1, 2 scale, and then they average that over nationally, and then they can describe that for different states. So these are representing the national averages with the blue dots, showing national averages of state metrics in June, and then the progression 3 months later into October. So what my takeaway is this from this, and you can go, I put the link there, you can read the full report for analysis. I think it's super, super helpful. But I see kind of 3 zones, right? There's the ones in yellow, and hey, like a lot of states are doing this moderately well, and that represents, I think it's 8 of the metrics there in that yellow zone. And then you can see how much improvement has happened over time. But a lot of metrics that are highly prioritized and needed are just, even with this feedback, are not becoming available. So it's just to provide some context as to some of the challenges that state are facing and producing the numbers that we know are needed. So how does Hawaii stack up in this report? We actually ranked number 9, tied with a few other states for 9th. Now, so to contextualize that, it's high in terms of nationally, but then the overall availability is only 37% of what the ideal target of all 15 metrics maxing out would be. So still a lot of room for growth, but I'm proud that, relative to other states, you really have to compare apples to apples. And I think sometimes there's an idealistic expectation about what we should be doing, and then trying to meet that with the reality of what we can reasonably do with the resources that we have. And I'm also proud that we only scored 13% in July, but as of October, we are currently working on a number. Even since this last came out, we've made a lot of improvements. So the analogy that comes to mind for me is, and it's relevant in terms of the emphasis on travel and flying, is that we are trying to build the plane while we fly it. And that's definitely resonates with me. That's how I felt along this process. And so I definitely want to recognize a few key partners that have been really indispensable in our evolution and progress that we've made. One is the Native Hawaiian Pacific Islander COVID-19 response team, Response Recovery Resilience, and have attended weekly meetings with them for about the past 6 months, and really gotten a lot of input on how to present racial data and address racial disparities in the state. And Hawaii Data Collaborative, I've definitely taken a lot of leads from them in terms of just that story approach and how to present data. So I'll talk real briefly about just our data sources and where it comes from, and then I'll jump into some examples. So our first most timely source would be the electronic laboratory records. And that's essentially a passive system when someone gets a test, as long as if it's a nucleic acid amplification test, a PCR, those are high complexity tests. They can't just be done by any provider. They need to be processed by one of the major clinical labs. And we have electronic feeds that come from those labs into our system. And so we're able to get just that basic information we need to identify new cases. And then secondarily to that, we have providers that are mandated and legally required to report cases to us within 24 hours. So there's a case report form that's available online. They send it to us, and it gives us more rich information than usually contained, and a lot of clinical information than what we would get in the lab records. And then finally, we investigate all cases, and there's a process of trying to reach them, contact them, and then understand more about the transmission history, exposure history. What people are often referring to as contact tracing is definitely one piece of the whole case investigation process. So three primary data sources here that drive our data. There is lots of other COVID related and even COVID health data that is not collected and does not come straight into DocD. So a good example of that would be the hospitalization data. And I think a lot of people would be just surprised at how fragmented our systems are in the state. And this is typical in the US, the way our health systems are structured. They operate very independently, and so there isn't great linkage between electronic health records, for instance, and the health department, like you would find it in many other countries. So it's just a challenge that we're up against, and so working on that to get the best data that we can. So now I'll jump over to the website. Can I get a thumbs up, Thomas, if you're seeing the website, or are you still seeing the presentation? Okay, cool. So this is, you can get here, the URL is health.hawaii.gov. There's a shorter version called COVID-19, or the longest version, coronavirus disease 2019. So our navigating, you would first arrive at our homepage. Internet, okay. And this is, you got the overview, lots of resources, things to get educational information about how to respond. And then we have our dedicated data page. So I'm just going to highlight a few features and functionality that you may or may not be aware of. I was pretty new to Tableau at the beginning of this pandemic, so that's just an example of having to learn and fly the plane at the same time. But I've had a lot of help from people like Data Collaborative, Hawaii Data Collaborative, and some other groups to help just kind of educate me and learn how to get the most out of this great visualization tool. So one of the things I'll show is this share button. And we do, because DocD is sort of the definitive source for the case data, we encourage people to host and embed the metrics that we show, and we also, as I'll describe in a minute, make the data directly available. So one thing you could do if you're managing a blog or a website is use this embed code, and that way it's updated as soon as it's updated on our site. It will be updated on your site as well, or you can use the link to our Tableau public profile. A lot of great options available with hover features, things like that. This is a new update. We were using ArcGIS for our maps, and we just transitioned over to maps in Tableau. And this is the sort of story model where you can go along the top and find out different characteristics of the maps. And a really great feature is, you'll see in this first view, the data download. So there's this CSV download file. You click that, it'll launch a new window in your browser, and then the file will appear down in your download bar there. So all the data that's produced each day, refreshed and available for people wanting to do their own analysis and take different perspectives on things. Another feature I'll highlight is you'll see a lot of these filters. So being able to drill down into the county level and even island level for some of these visualizations. Another one that's fairly new is this, because there's a lot of interest in travel and whether travelers and travel associated cases were residents or not, we built this view so that you can filter on county, and then you can hover to see the individual cases, or you can also view the table. And I've been checking this, a lot of times people want to know what's the latest up-to-date EPI, and I don't even necessarily go into my private secure records. I'll just go onto the web because it's so updated in real time and pretty visible and exposed on a lot of the elements that you could want. So like, for instance, here, an interesting feature would be to select, maybe you're interested in Kauai County, what percentage of cases that were travelers were residents versus non-residents. So far in December, that's 3 cases where the risk factor was known out of 3 total cases. And these are all travel associated cases, and all 3 of them were among residents. Whereas in the month of November, there were 39 travel associated cases, and it was a 54-46% split between residents and non-residents. But you can see I've filtered out all those cases with no travel history. So I can bring those back in, loads for a second, and I can see how travel associated cases compared to community associated cases in the table, and that filter would apply as well to the EPI curve visualization in the back. Another feature that I've been leveraging a lot is this tooltip hover option, particularly for this one. So like, I find that presenting cases has just the most straightforward interpretation. So that's why EPI curves are kind of front and center. But as soon as you start to want to make comparisons, and we frame this as how do Hawaii's counties compare to one another, to get that perspective, that population level perspective. And you'll maybe see curves where it shows just the actual case counts separated out by county, and it's not an apples to apples comparison because of the population denominator differences. And so to understand real level of activity and burden on resources, this view can help. But these numbers, you're starting to get into decimals, and well, this is 6.4, and how does that relate to the big numbers that people are used to following, like this 90? That has a more straightforward interpretation. It's the 7-day average of daily cases statewide. So those are the numbers that people are accustomed to. But when we want to make the county comparison, having this tooltip hover gives the interpretation. What is that 8.8? Or let's see, as of now, Maui is 7.3. So you got the summary up there, but 7.3. So that's saying that for every 100,000 people that live in Maui, there was an average of 7.3 newly reported cases per day for the 7-day period ending on December 8th. So just kind of gives the interpretation to hopefully clear up any misconceptions or confusion. A lot of emphasis and questions have focused around testing. And so this is a helpful chart, particularly, people are wondering about surge testing. So for instance, you can see here that statewide, there were an average of 720 tests per day performed over the past 7 days, and the positivity rate was 0.3%, so 3 per thousand. You can compare that to the non-surge testing, where the positivity was 1.9%, and that's accounting for a lot more volume. The test turnaround time, I'll note that this was just shown, but it's really interesting to compare. This shows all tests, and when you factor out the tests that are going to the mainland to be processed, the turnaround time is actually quite good. So, and we do see a lot of those surge testing as being less urgent, as opposed to if you have a urgent reason to be tested, then they're usually going to process that test locally. And so we especially look at this local turnaround, and we've been really fortunate to have these kinds of numbers. Shows the scaling up of our clinical lab capacity has been really excellent. And that's critical because that then relates to the case investigation process. So knowing that someone's a case is kind of the first step, and then that triggers this sequence of events where we try to contact them. And we see from this chart, which shows there's 2 different axes and allows sort of a sense of the denominator or the background activity that underlies the percentages. So the left axis here is showing the number of cases reported per week. And then, so you can see, for instance, on the week beginning of November 1st, there were 789 cases, and of those 789, 59% were successfully reached by our case investigators. And again, there's this sort of story layout where you can then, that kind of begs the question, well, why is it only 60%? And so we did an analysis and evaluation for the 1 month period from October 1st to 31st, and we'll be updating that probably next week, as there's a bit of a lag to give time for cases to become investigated and then processed into our system. But so for now, we're just showing October, but we'll have the November data shortly. And so of a subset that were evaluated, we see that a lot of times it's the quality of information that's collected by the providers and at the lab level. So we can only act on the information that we have. And so kind of circling back around to the providers to try to help them to understand how important that information is that they collect at that point, because that may be our best way to follow up. And then also participation, are people cooperative? And we found that cooperative responsiveness does vary over time and in different populations. And so just trying to spread that message of how important it is to cooperate with the health department, that we're not trying to get people in trouble, we're not law enforcement, we're just trying to protect people's health. And then timeliness is really critical, because it's nice if you're reaching them, but if you're reaching them 2 weeks after their infection, then you've kind of missed the boat and your opportunity to stop the chain of transmission. So it's another metric that we're following really closely. Our goal, so the red and blue here, is to demonstrate, our goal is within 2 days. And if we start to get outside of 2 days, like we were kind of early in August, and this really demonstrates the progress and changes that have happened in our case investigation, just optimizing efficiency, trying to use this process. So this data has been in demand for many months, actually, and a lot of the reason that it wasn't coming out is because we were pulling it together internally. Again, back to that analogy of building the plane and flying it. The mechanisms to collect this data just did not exist in our system. So we're having to build it out and train our staff on how to collect it in a systematic, standardized way while we're bringing on lots of new staff. So, it's easier said than done, but we recognize the importance for self-evaluation. I think that's what this chart is showing is, just the improvement over time as this process of evaluation allowed us to identify those kinds of bottlenecks. And then one of the things I'm trying to be better about as we go along is give better documentation. So, these terms maybe can take for granted that we use them day to day, but then turning around and trying to communicate the data to the public, how important that is to to provide the definitions and interpretations of those terms. So whether it's in a hover over for interpreting a particular value or metric, or whether it's just knowing what the labels and axes are actually talking about, try to be better about that. Outcomes, let's see, age distributions. Last one I'll highlight would be, I guess, the mask wearing, which is relatively new data. We've just had this for about 3 weeks, and this is collected from ESF8, and Gary Gloverin has a group study that he's been overseeing for several months now, and it's really helpful data. And this is one, if you look at the availability of metrics across states, very few states are reporting on this. And so that we have it at a longitudinal level at this quality. It's not self-report, which I would always be somewhat skeptical of, although it's nice when you're able to corroborate it. So the 80, we're seeing often 80% self-reporting mask wearing. And you do get concerned about the selection bias and things like that. This is observation-based data. So the fact that those are consistent gives you better confidence in the values there. And so it also added this metric that lets you track it over time. And you can see it's been a general positive progression. So that's been encouraging. I do think a lot about these feedback loops that we're able to develop by getting the data out there. It gives you kind of a baseline and something to set goals around and monitor progress. And so I don't know what the effect of, if this is, it's oftentimes it's a combination of effects. It's the great communications work that's being done. It's the grassroots community level efforts where people are really buying into things like mask wearing, and then making that the norm and helping to overcome barriers that people have towards that. And then hopefully there's a part to play with data sharing, that data sharing can drive action. And then last topic that I'll highlight that's, I think, super important is this just racial disparities. And so, this is nothing new to most people. We've been aware that Pacific Islanders account for 4% of the population of Hawaii, but 27% of the cases. Something that's recently added to this chart is the ability to toggle over to deaths and make that same comparison. So out of the 246 deaths, and there are certain exclusions that we apply when we start looking at different analyses. So this doesn't equal, the total, what I would call the grand total, and that's usually addressed in the footnotes here. But the point being that a lot of times there are cases that are Hawaii residents that get reported to us, but they're out of state. And so we don't tend to have great detailed information on that because it'll be investigated by our other state partners and colleagues, or maybe non-residents. And so if we're doing a comparison directly against Hawaii's population, then we wouldn't want to include non-residents because they wouldn't be included in the comparator population. So just with those exclusions in mind, out of the 246 deaths for which race was known, 24% of those were among Pacific Islanders. And again, they're 4% of the population. The next highest group would also be the Japanese. And with further analysis, we find that it has to do largely explainable by the age distribution, both in the underlying population and among cases. So if you just look at the underlying age distribution of different racial groups in Hawaii, we do see that there are many more Japanese people of Japanese descent who are over the age of 60, 70, 80 in the state. And then monitoring trends as well. So you can kind of toggle around. We definitely had a bit of a issue with missing data, of resources getting overwhelmed, or capacity getting overwhelmed in the month of August when we had that big surge where we were, easily keeping up with our 10 to 20 cases per day. And then within a matter of weeks, that shot up to 200 to 300 cases per day. And our resources just did not scale that quickly. And that's kind of something that's just always important to keep in mind and respect about this pandemic is because of the infectious nature. There's always that, and the short turnaround time between rounds of serial infections between multiple people is you always have that potential for exponential skyrocketing growth. And it's been pretty amazing that the state has only had one real exponential surge, and other than that, we've been managing it generally. But taking away the missing data, These are the counts and cumulative cases over time. And so this just helps. You can monitor the slope of the curve to help get a sense of the rate of transmission in different groups over time. So I think that's everything I wanted to cover. Yeah, so I'll stop there. I will say that I'm very eager for input and comments. I get complaints sometimes. We have an email address, and if there's a mistake in grammar or a number seems off, we'll hear about it. And I'm always glad to have errors pointed out for sure. But also looking for any type of input on what do people think is working well and they want to see more of to keep doing, and what are we not doing that you would like to see. And we'll definitely take that into consideration. A lot of times there are limitations and barriers either around privacy or resources that do prevent us on providing certain metrics, but we are looking for ways to grow and communicate better. So looking forward to this Q&A session.
Awesome, thanks so much, Josh. This was, and I'm sure I speak for everybody on the webinar, but this was super helpful. I learned a ton, and I learned that I need to spend more time definitely reviewing all the great updates that you've added, you and your partners have added. We have a bunch of questions, and we have 15 minutes, so hopefully we can get through all of them. First one, does the non-resident data include the safe travel reports as well? Is there a direct feed from safe travels into Maven or other databases?
Yeah, that's a good question. So safe travels is a totally separate database, and they do not feed into Maven or our ELR. So our ELR feeds to our local providers only. So those are two completely different systems, and that is not. We do find out about cases from safe travels, different mechanisms, and we do investigate those, but it would be a separate data stream.
Awesome. And since we're on this, and keep sending questions in, everybody, and comments for Josh. Since we're on this topic of travel related, you know, when you were showing the breakdown from, you know, clusters or resident, non-resident due to travel, non-travel, does it go far back? Let's just say there's a cluster due to someone who was a close contact of a returning resident. Is that cluster attributed to travel, or is that going to be attributed to community spread?
Yeah, it's a great question, and one that we grapple with a lot, because you set up these boundaries and classifications and categorizations, but human behavior and situations, there's a lot of gray areas. So our definitions that we use, go back to that. What was it? Travel associated. Okay, here we go. Back to chart and try to make these a little more obvious, but we have kind of some definitions here. So community associated indicates the person was most likely infected from within the community, while travel associated indicates the person was most likely infected outside of Hawaii or by having close contact with a confirmed case who had recently traveled. So we'll go one step downstream, but not further than one step.
Okay, no, that's very helpful, at least in terms of, you know, people are so, and I know this is a big topic within HiPAM, but also outside of HiPAM as well, in terms of what is trying to get a sense of the true impact of travel, especially trying to estimate with this the Safe Travels Hawaii and then the single test, trying to correlate that with what we're seeing from, you know, the data that we get from DocD. So that definitely helps clarify. So thank you for that. Another question from Tiana. She says, we often hear, as you have described, about the data that would be helpful to have reported but isn't. Do you have any thoughts on which agency has responsibility from improving that shortcoming, or how this situation should be improved? And obviously, we know everybody wears multiple hats, so you know, whatever you can speak to this would be helpful.
Yeah, I'll just say it's a great question, and one that I've been asking myself a lot, and I don't have. It's kind of more a policy question, and that's probably just above my head. So I'll just say that I think it needs to be addressed, and I think data is a priority. I appreciate the work that Data Collaborative is doing to just bring attention to the importance of data and the need to have data inform policy and intervention. But yeah, sorry, it's not a great answer. I don't know who's responsible for statewide, but definitely agree.
Awesome, thank you. And then next one from Itzvan. Are I'm assuming he's asking if all the data is downloadable or only a subset of the
Yeah,
data is downloadable.
I'll point out the data that is downloadable. So it's the map data, the case data, let's see, main dashboard. So this CSV contains the data that's behind the epi curve and the data that's behind this summary metrics. And then the third one that is downloadable, I'll go down to it, would be this race data. So you can get the race data if you click all the boxes, and then this guy right here, you can get the crosstab, and that'll download let's see, it's ratio 2. So those are the ones that are available. It's a little tricky in terms of not wanting things to be identifiable, basically. So that's why we try to represent more just the aggregate trends and try to answer the questions that people would have. And then hopefully it's these data that we're making available that are the ones that would be most useful to people to do their own models and trends and things like that.
Awesome, thank you. Question from Monique, Dr. Shiba. Is timeliness of reaching, I'm assuming she meant reaching close contacts during the contact tracing investigation, improved because we have had fewer cases now than we had during the surge in August, and I'm sure some combination of that with our contact tracing numbers as well.
Yeah, I'll just say it's a ratio of resources to cases, and so we saw the extreme worst end of that in October, where our resources capped out. They were suited towards the activity that was happening in May and June, which was single and maybe double-digit cases. And then now we're getting into a position of more resources, and so the question then becomes, what is the right mixture, and how do you scale up? And I think there's a recognition that when it comes to personnel and all these other resources, you can only scale them so quickly because there's training and space and equipment and all these other logistical factors that come into play. I'll add that the National Guard has been tremendous in their support and just efficiency and logistics support that they've provided, and we've leaned on them very heavily. So,
sure, thank you so much for that. Another one from Itzvan. Do you have any plans, or I'm assuming, does Doc D have any plans to include any cluster information, for example, index case to related cases? And I will speak to the fact that you guys have done a great job with your weekly cluster reports, but I'm gonna guess for Itzvan that he's meaning like any further detailed reports or data.
Yeah, no, I'm glad you asked that, because I would say the 3 things that I have on my top priority of next viz to work on and data to communicate more effectively would be, number 1 is clusters. So they're in these reports, and if you're looking for that format and type of information, they're good reads, and they're very thorough and well put together, and so I recommend checking that out. But I think we also need to translate that into other formats, and so I'm working on how to do that. I'd like to produce an epi curve that stratifies on whether the case was cluster associated versus sort of sporadic community type source, and then also I'll say the investigation and tracing metrics. This is like version 1.0, and there will be new iterations of that as well.
Awesome, thank you so much. And from Tom out of Maui, is Hawaii using or thinking of using wastewater trends of COVID testing to map to what we might be looking at soon in reported cases?
I can't speak to that too much, but I know we are sharing some data with some researchers at UH. So I don't know if anyone else in the group is more familiar with that project. So I know it's been used in some other places. It's not a DOH-led initiative. I think we're trying to keep our eye on the ball of tracking the cases, but there's definitely opportunities there for our partners that have the laboratory capacity and science tools to look at wastewater and see how that might correlate and predict things.
Perfect. A question from Francis. Does reduction in the contact tracing workforce plan for 2021, is that a cause for concern for a potential future spike?
Yeah, I mean, it's hard. I've hesitated to try to predict the future just because there's so many factors, and And I think it remains to be seen what the contact tracing workforce will actually look like. I think there's talk about, what is the federal support package going to look like? Will it come, and what would that mean for our workforce? I think it's something to consider, because our ability to manage the transmission on a real-time person-to-person level and track it does depend on our workforce. And so if there were to be a reduction in support and that workforce, I know the state is trying to manage its budget as well. So it's something that we would all have to consider in terms of our overall capacity to respond, and whether that, I hesitate to say that any one thing would cause a spike, that those types of causal relationships, because a lot of times we see that when one thing lessens, there are other things that can step in and fill the gap. So we'll just have to see.
Awesome. I think we got all of the questions from our attendees today, and we have about 5 minutes left. I will ask one more, and I promise this is not, this is just out of curiosity. So we've been seeing other countries utilize technology to improve contact tracing information, whether it's QR codes linked to an app for ease of use for locations. I believe DOH has created one, and I apologize for not remembering the name. But do you guys have any plans on working with that? I don't think it's Safe Travels Hawaii, but it's another app. Or do you think that might be a way forward, especially if contact tracing, the physical contact tracers might be decreased?
Yeah, I think that's a great, I do work on the Aloha Safe Alert. In my role as an epidemiologist, I'm kind of the DOH lead for exposure notification technologies. And we are, tentatively stepping into that space. We've seen it launched in different states, and we think it holds a lot of promise, a lot of potential, especially for its scalability. There's, I think my biggest concern is around adoption, because in order for it to be effective, you need to maximize adoption. And I've just had questions around, do Americans with their really, fierce independence and love of privacy, are they going to go for a technology that now, I've done all the investigation, and the way that the technology is set up is very privacy forward. And so that's why we use the Bluetooth as opposed to GPS, because GPS could track your location, and that's information that people probably want kept private and don't want tech companies or health departments even having access to. And so this GAIN, Google Apple exposure notification protocol, is very privacy focused. And I think it does hold a lot of promise, especially when you think of the scalability and potential for workforce reductions that could happen. Leveraging technology is something we carry in our pockets. If that can help in any way, you hear the Swiss cheese model. This in and of itself has a lot of holes, but layered on to lots of other interventions and prevention mechanisms that we have, it may help. So I'd say that's what I can say to that.
Awesome. Thank you so much. I think you just might have volunteered yourself for a future presentation, because I think this would be great. I mean, just to educate the public, but technology done the right way, especially like you aptly pointed out, privacy concerns is huge and front and center in the United States. But if we can leverage it to the best of our capabilities, it might increase the data that we get. And I know data is of interest for this group, specifically for HiPAM. So,
and I'll add to that the way it's designed is we'll have to be very patient and reserved about the data that we expect from it, because it's privacy forward. There are massive limitations into the information that you can collect about it. And so that's kind of a general limitation about on really evaluating the effectiveness of these tools, is because there's so many privacy restrictions. But I'm all on board with leveraging any technology that can help and that protects privacy. So. Awesome.
Well, I want to say thank you on behalf of HiPAM and all of our members and attendees. Thank you for sharing this great information and for your collaboration, and we're excited to move forward with you and the rest of our partners. So with that, I want to wish everybody a happy weekend, stay safe, and we will see you guys next week, Thursday, where we have, I believe, Let me see if he's on. One of Marguerite's students, I believe, Ethan, is presenting next week on an update on some of his research. So excited for that. But with that, thank you, everybody. And we will see you next week. Take care and aloha.